Okay, let's unpack this. Have you ever truly stopped to think about the incredible, meticulous dance that goes on behind the scenes to keep you safe and sound at the dentist's office?
Hmm.
It's far more intricate, more fascinating, and frankly more reassuring than you might ever imagine. We're about to pull back the curtain on the unseen choreography of safety, the meticulous science that ensures every tool, every surface, every single interaction is as absolutely clean and safe as it can possibly be.
Yeah.
It's an invisible shield, really, built with precision.
Indeed, what seems like a routine visit, quick checkup or a simple filling, actually involves this meticulous dance of science and protocol.
Right.
This entire system is relentlessly aimed at preventing the spread of unseen enemies. The microorganisms that can cause infection.
The bugs.
Exactly, the bugs.
Yeah.
It's a field where precision and unwavering adherence to strict guidelines are not just good practice, they're absolutely paramount for maintaining public health and trust.
That's right. And today, we are embarking on a deep dive into something foundational to your health. Dental sterilization and disinfection principles. Our source material for this deep dive is a truly comprehensive guide, one that meticulously outlines the fundamental practices designed to prevent infection transmission in dental environments. And let me tell you, when you dig into this, it really is eye-opening.
This guide lays out the very bedrock of safety protocols, detailing precisely how the dental profession actively combats the spread of pathogens. It's not, a haphazard collection of rules.
Wow.
Rather, it's an intricate, deliberately designed system engineered to protect not only patients, but also the dedicated dental team themselves. Every single step has a scientific rationale behind it.
Our mission today is clear. We want to extract the most critical nuggets of knowledge from this complex topic, help you understand the why behind these crucial processes, and cultivate a real appreciation for the numerous layers of protection that are paramount to patient and staff safety in dentistry. Our goal is to give you a genuine shortcut to being truly well-informed on something vital, yet often completely invisible during your dental visit.
By the end of this deep dive, you'll gain a thorough understanding not just of what sterilization and disinfection are, but, more importantly, why they are absolutely non-negotiable processes in a modern dental setting.
Non-negotiable. I like that.
Absolutely. You'll see exactly how they contribute to creating a truly safe clinical environment. It's about recognizing the deliberate, scientific approach that underpins every single procedure to minimize risks for everyone involved.
So let's start at the very beginning and get our foundational definitions crystal clear. Because while you might hear sterilization and disinfection used interchangeably in casual conversation, especially outside of a clinical setting,
All the time.
they are in fact distinct processes with very different outcomes. Understanding this distinction is where we lay the essential groundwork for everything else.
You've hit on a crucial point there. Sterilization, for instance. It's not just about being really clean. It's defined as an absolute process.
It's absolute.
Absolute. What that means in practical terms is that it kills or removes all living microorganisms from a material or an object. And when we say all, we truly mean it. This crucially includes even the most resilient forms of microbial life, like bacterial spores.
Ah, spores. Those are the really tough ones, right?
Exactly. Think of it this way. An object is either sterile or it is not sterile. There's simply no intermediate state, no almost sterile.
Okay.
This level of absolute certainty is non-negotiable and absolutely necessary for critical medical tools, those instruments that might penetrate soft tissue or bone or enter the vascular system.
Right, anything invasive.
Precisely. In those situations, any surviving microorganism could lead to a serious, potentially life-threatening infection.
So it's the ultimate clean, the absolute kill. It sounds like a total annihilation of microbes.
That's a good way to put it. Total annihilation.
And while most of us immediately think of intense heat when we hear sterilization, your sources show that chemicals can also achieve this same absolute state, which to me is pretty fascinating.
Yes, certain chemicals can achieve it, though heat is definitely the primary method.
Here's where it gets really interesting, because we're about to dive into the powerful world of sterilization methods, starting with what's often considered the undisputed gold standard: heat.
Heat is indeed the cornerstone.
Yeah.
And for very good reason. It's consistently the most reliable and universally applicable method for achieving that absolute sterile state.
Why heat? What's it actually doing to the microbes?
It's incredibly effective because of its fundamental mechanism. Heat denatures and coagulates the very building blocks of life for microorganisms, especially their proteins.
Denatures, like cooking an egg.
Exactly like cooking an egg. The clear liquid protein turns solid and non-functional. That's essentially what happens to the microbial proteins when subjected to sufficient heat. They're irreversibly damaged.
So when we talk about sterilizing dental instruments, heat is the most reliable method. But even within heat, there are different approaches, and one particular method stands out as the true workhorse of dentistry: moist heat, which we commonly experience through autoclaves.
Absolutely. Moist heat, specifically steam under pressure in an autoclave, kills microorganisms by that process of denaturation and coagulation of their proteins. The key to its power lies in how steam works.
Okay.
When superheated steam comes into contact with the cooler surfaces of the instruments, it rapidly condenses. And when it condenses, it releases a tremendous amount of latent heat that's stored energy that is suddenly unleashed.
Latent heat, like a burst of energy.
A powerful burst, yes. This rapid and potent heat transfer quickly penetrates the material and effectively kills the microbes. The pressure inside a closed chamber like an autoclave is critical because it raises the temperature of the steam far above the normal boiling point of water, well above 100 degrees C.
Right. Water normally boils at 100 degrees C.
Correct. But under pressure, it gets much hotter. For example, many dental autoclaves operate at temperatures up to 134 degrees C. This superheated pressurized steam is what gives it such formidable killing power, reaching places that dry heat might struggle to penetrate quickly.
That rapid penetration and concentrated heat release sound incredibly effective. But you mentioned something crucial that's often overlooked in casual discussions: the role of air expulsion.
Oh, yes.
Why is getting rid of the air so important for the steam to do its job properly? It seems like a tiny detail, but you're saying it's absolutely vital.
It's a remarkably vital detail, and it's one of the biggest reasons for sterilization failures if not properly managed. Think of it this way. If air remains trapped within the chamber, especially inside hollow instruments or complex packaging, it creates air pockets.
Air pockets, like little bubbles.
Exactly. And steam cannot effectively penetrate air. So for the steam to condense properly and deliver that lethal latent heat to every single surface of every instrument, those air pockets must be expelled.
I see.
If air remains, it acts as an insulating barrier, preventing the steam from contacting all surfaces, leaving cold spots where microbes could survive. This is precisely why the type of autoclave and its air removal mechanism matter so much.
So that leads us directly to the different types of autoclaves. What are the main ones a dental office might use, and why would they choose one design over another, especially given that challenge of air pockets?
Good question. The two primary types you'll find are vacuum autoclaves, often referred to as Type B or Type S, and gravity displacement autoclaves, or Type N.
Vacuum and gravity.
Vacuum autoclaves are generally considered superior, particularly for dental practices, because they employ a powerful vacuum pump to actively evacuate all the air from the chamber before the steam is introduced.
So it sucks the air out first?
Precisely. This creates a near-perfect vacuum, ensuring deep and thorough steam penetration into every crack, crevice, and lumen, the hollow parts of the instruments.
Lumens, like inside dental handpieces.
Exactly. This is especially critical for complex hollow devices like those intricate dental handpieces, which have internal channels that are very difficult for steam to reach otherwise. They're like tiny, high-tech plumbing systems.
Okay, so vacuum is better for the complex stuff. What about gravity displacement?
Gravity displacement autoclaves, on the other hand, operate on a simpler principle. They rely on the fact that steam is lighter than air.
Okay.
So as steam enters the chamber from the top, it simply displaces the cooler, denser air downwards and out through a vent at the bottom.
Pushes the air out.
Right. While effective for many solid unwrapped items, they aren't as efficient as vacuum types for highly complex or hollow instruments where air pockets can more easily persist, potentially leading to incomplete sterilization.
Got it.
For maximum assurance, especially with modern dental tools, vacuum autoclaves are the preferred choice.
Got it. So vacuum autoclaves are the go-to for those incredibly complex dental tools with their internal channels. What about the actual cycles, and how widely are these machines used in dentistry and beyond? What kind of conditions are we talking about?
For most dental instruments, the recommended sterilization cycle in a moist heat autoclave is typically 134 degrees C, held for a minimum of 3 to 4 minutes.
3 to 4 minutes, okay.
At a pressure of approximately 207 kilopascals, which, to put it in more common terms, is about 15 pounds per square inch, psi, or roughly 2 atmospheres of pressure.
Wow. That's quite a bit of pressure.
It is. That's significantly higher than atmospheric pressure and ensures that superheated steam can do its work effectively. This specific cycle is effective for both wrapped instruments, those sealed in sterilization pouches to maintain sterility after removal, and unwrapped instruments, typically used immediately.
And these are used elsewhere too.
Oh, absolutely. Beyond just dental instruments, autoclaves are true powerhouses across various settings. They're widely used for sterilizing culture media in microbiology labs, all the materials used in operating theaters and hospitals, and a broad range of laboratory equipment. Their versatility and reliability make them indispensable for infection control in many critical fields.
That's a lot of variables. Temperature, pressure, time, air removal. How do dental practices ensure, beyond a shadow of a doubt, that the autoclave actually worked? What are the checks and balances that guarantee your safety?
That's a critical point. Monitoring sterilization processes is absolutely crucial. It's not enough to just press a button and hope. You need concrete proof.
Right.
This is done using a multi-pronged approach, often referred to as the 3 pillars of proof: mechanical, chemical, and biological indicators.
3 pillars. Okay, what's the first one?
First, you have mechanical indicators. These are the built-in gauges and displays on the autoclave itself, monitoring its temperature, the pressure inside the chamber, and the holding time of the cycle.
Like the dashboard on the machine.
Exactly. They provide a real-time, immediate check that the machine is operating within its specified parameters. It's your very first line of verification, a quick glance to see if the process even started correctly.
So a quick glance to make sure the machine is doing what it's supposed to do. What's the next layer of proof?
Next are chemical indicators. These are strips, specific markings printed directly on sterilization pouches, or tape that is placed on the outside of instrument packs.
I think I've seen those little strips change color.
Yes. These indicators undergo a visible color change when exposed to specific temperatures or conditions. For example, a strip might change from pink to brown when it reaches a certain temperature inside the autoclave.
Okay.
They're a rapid visual confirmation that the instruments have, at least, gone through the sterilization process and reached certain temperature thresholds or steam penetration levels. However, it's vital to remember that they don't confirm that all microorganisms were destroyed, only that the conditions for sterilization were met.
So it shows the conditions were right, but not definitively that everything's dead.
Precisely. They're like a progress report, not a final pass-fail grade.
And then what you call the definitive test, the ultimate proof, I imagine, is the biological indicator. This sounds like the canary in the coal mine for germs.
Precisely. Biological indicators are, without question, the most definitive test for sterilization efficacy. They are, indeed, the gold standard.
How do they work?
These involve using highly resistant bacterial spores, specifically Bacillus styrothermophilus, for moist heat autoclaves. These particular spores are chosen because they are far more resistant to heat than common disease-causing microorganisms.
So they're like the superbugs of the spore world.
You could say that. They are known to be reliably destroyed at 121 degrees C within 10 to 20 minutes, which is well within the standard autoclaving temperature and timeframes.
Okay.
If the autoclave successfully kills these Bacillus styrothermophilus spores, the toughest microbial adversaries in this context, then it's a powerful and reliable confirmation that it has killed all other less resistant microorganisms.
So it's essentially putting the sterilizer through a super rigorous stress test every time. And how often are these ultimate tests performed to ensure ongoing safety?
They should be performed at least weekly to ensure ongoing effectiveness.
Weekly? Wow.
Yes, and critically, whenever an autoclave is new, has undergone significant repairs, or after any major maintenance. It's not a once-and-done test. This constant verification is crucial for maintaining patient safety. If we connect this to the bigger picture, biological indicators are your ultimate peace of mind. They are the scientific, data-driven proof that the process truly worked every single time. It's about science, not just good intentions, guaranteeing your safety.
So moist heat is the champion, the go-to for most instruments. But what about dry heat? When is that used in a dental setting, or more broadly, and what are its limitations?
Dry heat, typically administered in a hot air oven, is primarily used for items that are heat-resistant but are not suitable for moist heat sterilization.
Why wouldn't something be suitable for moist heat?
Well, perhaps they might corrode or degrade if exposed to steam and moisture, or steam simply cannot penetrate them effectively. We're talking about things like delicate glassware, such as glass syringes and petri dishes,
Okay.
or certain finely crafted surgical instruments like scalpels and scissors that might be susceptible to rust or dulling in a moist environment. It's also critical for sterilizing certain chemicals or oils that steam simply cannot penetrate effectively to achieve sterilization.
And how does this cycle for dry heat compare to moist heat? I imagine it's quite different given the absence of steam and the reliance on just hot air.
It is indeed strikingly different. Dry heat operates at a higher temperature for a much, much longer duration to achieve sterilization.
Higher and longer. How much?
It requires prolonged exposure, typically to temperatures ranging from 160 to 180 degrees C for a substantial period, often 2 hours and 30 minutes, or even longer depending on the item.
2.5 hours. Wow, compared to 3 or 4 minutes.
Exactly. This extended time at elevated temperature is necessary to ensure thorough heating throughout the entire object and to effectively destroy all spores through a process called oxidation, essentially burning them up at a microscopic level.
And do they monitor dry heat the same way?
Similar principles apply. Monitoring dry heat also involves thermocouples for precise temperature checks, chemical indicators for quick visual confirmation, and for the ultimate proof, Bacillus subtilis spores as the biological control.
Different spores for dry heat.
Yes, because B. subtilis is more resistant to dry heat than B. Stereothermophilus is to moist heat. You always use the toughest relevant challenge.
So heat, in its various forms, is our sterilization superstar, the absolute killer of microbes. But then there are some heat methods that fall short of full sterilization and are used primarily for disinfection. This raises an important question. Why aren't these methods considered true sterilization? What's the fundamental difference in what they achieve, and why is that distinction so important for patient safety?
That's a critical distinction, and it goes back to our foundational definition of sterilization as an absolute process that kills all forms of microbial life, including those incredibly resistant bacterial spores.
Right, spores again.
Always the spores. While these methods use heat, they simply don't achieve that absolute destruction. Take boiling, for example. Boiling at 100 degrees C for a period of time effectively kills most vegetative bacteria. These are the actively growing, multiplying cells that cause many common infections.
Okay, kills the active ones.
Yes, but boiling simply cannot reliably destroy those tough, dormant bacterial spores. Think of spores as microbial bunkers. They can withstand extreme conditions.
So boiling isn't sterilization.
Definitely not. Therefore, boiling is considered a method of disinfection, not sterilization, and you would absolutely never use it for surgical instruments that need to be truly sterile for procedures where soft tissue or bone is penetrated.
And what about pasteurization, which most of us associate with milk and food safety? How does that fit into this spectrum of heat-based decontamination?
Pasteurization is another excellent example of heat used for disinfection, not sterilization. It involves relatively mild heating, for example, holding a liquid at 63 to 66 degrees C for 30 minutes, or a rapid flash pasteurization at 72 degrees C for 15 seconds, typically for liquids like milk or fruit juice.
Much lower temperatures.
It's lower. Its primary purpose is to significantly reduce the overall microbial load and to destroy specific heat-sensitive pathogens that might cause disease or spoilage, improving safety and shelf life. But it's crucial to understand it's not sterilization, because those tough bacterial spores can and do survive pasteurization.
So while your milk is safe to drink, it's not truly sterile in the clinical sense.
Precisely.
And then there's tyndallization that sounds quite specific and rather time-consuming, heating something repeatedly. What exactly is that, and why would you ever choose such a method?
Tyndallization, sometimes called intermittent sterilization, is a very specific and indeed time-consuming process. It involves heating a substance to 100 degrees C for 20 minutes on 3 successive days.
3 days?
Yes, with periods of cooling at room temperature in between. The ingenious, albeit specific, idea behind it is this. The first heating kills all the active vegetative microbial cells.
Okay.
During the cooling periods that follow, any bacterial spores that survive the first heating are given a chance to germinate into more vulnerable vegetative cells.
Ah, so they trick the spores into waking up.
Exactly. Then, the subsequent heating cycles on the second and third days kill these newly germinated, now vulnerable cells. This method is specifically and almost exclusively used for heat-labile substances, things like serums, sugar solutions, or egg products that would be damaged or denatured by the higher temperatures and pressures of traditional autoclaving.
So it's a very niche application.
Very niche. While it's a form of heat treatment, it's about destroying vegetative cells and germinating spores in stages, and it's less commonly used in modern dental or medical practice due to its complexity and the availability of other methods. Again, it's about targeted destruction of vulnerable forms, not necessarily a definitive single-cycle spore kill like true sterilization.
So while heat in its various forms is clearly dominant for sterilization, what other methods can achieve that absolute sterilization, especially for materials that simply can't take the heat of an autoclave or a dry heat oven?
Beyond heat, we have powerful methods that achieve sterilization through entirely different mechanisms. One significant one is radiation sterilization.
Radiation, like X-rays.
Sort of. It's like using light or invisible energy waves to obliterate microbes.
And within radiation, there's ionizing and non-ionizing, right? They sound very different.
Correct. And they operate on very different principles with distinct applications. Ionizing radiation, which primarily includes gamma rays and X-rays, has extremely high penetrating power.
Penetrating power, okay.
It's highly effective at destroying bacterial endospores in vegetative cells by directly damaging their DNA and other cellular components, making replication impossible. However, it's interestingly less effective against certain viruses.
Really? Less effective on viruses?
For some, yes. This method is predominantly used commercially on a large scale for sterilizing heat-sensitive, single-use, disposable items. Think of things like prepackaged syringes, catheters, surgical sutures, and a vast array of prepacked medical kits you might see in a hospital or clinic.
The stuff that comes in sealed packages?
Exactly. Because it doesn't involve appreciable heat to achieve sterilization, it's often referred to as cold sterilization, which is a crucial benefit for materials that would melt or degrade in an autoclave, like many plastics.
Okay, that makes sense. So what about non-ionizing radiation, like UV light?
Then you have non-ionizing radiation, most commonly ultraviolet, or UV light. UV light is lethal to most vegetative bacteria because its specific wavelength denatures their proteins and interferes with their DNA replication, essentially scrambling their genetic code.
Sounds pretty effective.
It is, but its major limitation is a critical one for medical applications. It doesn't penetrate well.
Oh.
It's easily blocked by even thin layers of glass, dirt, water, or even a microscopic layer of organic material like dust. And crucially, it's largely ineffective against bacterial spores.
Spores again.
Oh.
And no penetration.
Right. So its primary use is for surface disinfection in controlled, enclosed areas, such as microbiology labs to keep benches clean, within inoculation hoods to maintain a sterile workspace, or even within operating theaters to sterilize the air or expose surfaces, but never for internal instruments that need deep penetration. It's great for line-of-sight cleaning, but not much more.
That makes perfect sense. It's good for a direct hit on a surface, but absolutely not for anything hidden or complex. What about filtration? That sounds like a purely physical barrier method, just trapping microbes.
Filtration sterilization is exactly that, a physical separation rather than destruction. It's a bit like a superfine sieve for liquids or air.
A sieve for microbes.
Essentially, yes. It's particularly useful for sterilizing heat-labile liquid substances that would be irrevocably damaged by heat, such as pharmaceutical solutions, ophthalmic eye solutions, liquid culture media used in labs, certain oils, or even specific antibiotics.
How fine does this sieve have to be?
Incredibly fine. The liquid is simply passed through a membrane filter with pores so incredibly small, often measured in nanometers, that they're small enough to physically trap bacteria and even the tiniest bacterial spores, allowing only the sterile liquid to pass through.
Wow. And it works for air, too.
Yes, air can also be sterilized by filtration. This is done using specialized surgical masks worn by dental professionals or high-efficiency particulate air, known as HEPA, filters found in controlled environments like laminar flow cabinets or even some advanced air purification systems.
IKEA filters, right.
This is fascinating because it's a physical separation, not destruction, of microbes, but it achieves sterility by removing them entirely from the fluid or airstream.
So when heat isn't an option for achieving that absolute sterilization, certain powerful chemicals step in to fill the gap, destroying even those tough spores. What are the heavy hitters in chemical sterilization that dental and medical professionals rely on?
When heat isn't feasible, certain chemical agents, known as chemical sterilants, are employed. Glutaraldehyde is one such potent chemical.
Glutaraldehyde, okay.
A 2% buffered solution of glutaraldehyde is remarkably effective. It can rapidly disinfect objects within 10 minutes, but more importantly, given sufficient contact time, it can destroy all bacterial spores, usually within 12 hours of exposure.
12 hours? That's a long time.
It is, but that prolonged contact makes it a true sterilant. It's particularly valuable for sterilizing delicate instruments that cannot withstand the high temperatures of autoclaving, such as flexible fiber optic endoscopes or certain intricate dental handpieces that might be heat sensitive.
But are there downsides?
Yes. It's also known as a respiratory irritant and a sensitizing agent, meaning it can cause allergic reactions in some individuals upon repeated exposure. So handling requires careful ventilation and personal protective equipment.
Okay. What else is used?
Another significant chemical sterilant is ethylene oxide gas. This is a colorless gas that is used for gaseous sterilization, often in specialized large chambers.
Gas sterilization.
Yes. It's incredibly highly penetrating, which means it can permeate deep into tight spaces and porous materials very effectively. Ethylene oxide is active against all types of bacteria, bacterial spores, and viruses by inhibiting their vital proteins and nucleic acids, essentially rendering them inert and unable to replicate.
So it gets everywhere. What's it used for?
It's predominantly used for heat-sensitive disposable plastic items, like prepackaged Petri dishes, surgical sutures, and a vast array of single-use dental equipment that would melt or deform in an autoclave.
Also sounds like something you need to handle carefully.
Absolutely. It also requires careful handling due to its flammability and toxicity, and items sterilized with it often necessitate a long aeration period after sterilization to allow any residual gas to dissipate safely before use.
Now let's shift gears to disinfection. If sterilization is the absolute total annihilation of microbes, what exactly is disinfection and where does it fit into the safety puzzle? It seems like it's a step down, but still incredibly vital.
You framed it perfectly. Disinfection is a process that specifically aims to destroy or remove pathogenic organisms, usually from inanimate objects. The key distinction from sterilization, and this is crucial, is that disinfection excludes bacterial spores.
Right, doesn't kill the spores.
Exactly. While it targets most disease-causing microbes, the ones that are actively growing and multiplying, it doesn't guarantee the elimination of those incredibly resilient dormant spore forms. Another important point is that disinfectants are generally toxic to human tissues at higher concentrations, which limits their direct application on living beings.
So you wouldn't put disinfectant directly on skin, usually?
Generally not, which leads us closely to the concept of antisepsis. Antisepsis involves the application of a chemical agent directly to exposed body surfaces, such as skin, mucous membranes, or to wounds.
Like using an alcohol wipe before a shot.
Precisely. Its purpose is to destroy or inhibit vegetative pathogens on living tissue, where using a disinfectant would be too harsh or toxic. This brings us to an important rule of thumb. All antiseptics can be used as disinfectants, as they are strong enough to kill microbes on inanimate objects. However, not all disinfectants can be used as antiseptics, precisely because of their toxicity to living tissues. Think of alcohol wipes for your skin versus bleach for a countertop.
Got it. Same idea, different strength and application. So, if you were to conjure up the ideal disinfectant, what properties would it have? What would that magical solution look like?
Ah, the ideal disinfectant. If only. It would be a miracle worker. It would have an incredibly broad spectrum of activity, meaning it's effective against a wide range of bacteria, fungi, and viruses, including the tough ones.
Kills everything.
Kills almost everything. It would be effective even at very high dilutions, stable over time so it doesn't lose its potency quickly, completely odorless, and easily soluble in both water and lipids to penetrate different substances. Speed of action, effectiveness in varying pH levels, and an inexpensive cost would also be crucial for practical widespread use.
Sounds perfect, but
here's the practical reality check. In practice, disinfectants are significantly affected by organic matter, things like blood, saliva, pus, or tissue debris.
Organic matter gets in the way.
Big time. This organic material can literally shield microorganisms, enhancing their survival and actively interfering with the disinfectant's action. This immediately raises a very important question. Why is that cleaning step so important before any disinfection can even begin?
Because the disinfectant can't get through the gunk.
Exactly. Because if the surface isn't physically clean, the disinfectant simply can't do its job effectively, no matter how potent it is.
That's a crucial point that many people might overlook, and it directly leads us into the idea that not all disinfectants are created equal. Just like in many areas of life, there's a spectrum of effectiveness when it comes to disinfectants. They're carefully categorized by their potency, right?
Exactly. Disinfectants are tiered based on their ability to kill different types of microorganisms, reflecting their potency and the specific applications for which they are best suited. We classify them into high level, intermediate level, and low level.
Okay. Levels of disinfection. What's high level?
High-level disinfectants are incredibly active against a very broad range of microbes, including gram-positive and gram-negative bacteria, Mycobacterium tuberculosis,
The TB germ.
right, which is quite resistant to most viruses, and fungi. Crucially, and this is where they differ from true sterilants, they're not necessarily active against all bacterial spores.
Still might miss some spores. What are they used for?
These are typically used for what we call semi-critical items, instruments that come into contact with mucous membranes or non-intact skin, but do not penetrate sterile tissue. Examples include glutaraldehyde, hydrogen peroxide, and various chlorine compounds.
Okay, semi-critical items. What about intermediate level?
Then we have intermediate-level disinfectants. These effectively destroy Mycobacterium tuberculosis, vegetative bacteria, most viruses, and fungi. However, they destroy few, if any, bacterial spores.
Even fewer spores killed. Use cases.
These are typically used for surfaces or instruments that don't directly contact mucous membranes or broken skin, but still need a significant level of decontamination, such as dental countertops or impression materials. Common examples include alcohols, iodophor compounds, and phenolic compounds.
And finally, low level.
Finally, there are low-level disinfectants. These are designed to kill most bacteria and fungi, but they are not effective against Mycobacterium tuberculosis or spores.
So the least potent. What are these for?
Their application is for non-critical items, surfaces or objects that only contact intact skin, like a dental chair armrest or the exterior of an X-ray machine. Quaternary ammonium compounds are a common example here.
So the level matches the risk.
Precisely. What's truly fascinating here is how the choice of disinfectant is not random. It directly ties into the precise risk level of the instrument or surface. It's a carefully calibrated decision based on the potential for infection transmission.
That tiered approach really helps clarify things, making sense of why different solutions are used for different purposes. Now, let's zoom in on the specific chemical disinfectants you're most likely to encounter or benefit from in a dental setting. What are the key players here, and what are their strengths and weaknesses?
Okay, let's look at the workhorses of chemical disinfection in dentistry. First up are alcohols, typically used at 70% concentration, like ethyl or isopropyl alcohol.
Rubbing alcohol, basically.
Pretty much. They are good bactericidal and fungicidal agents, meaning they kill most bacteria and fungi quite effectively. They're commonly used for skin antisepsis before injections, helping to quickly clean and reduce microbes on the surface of your skin.
But limitations.
Yes, crucial limitations. They are not sporicidal, meaning they don't kill bacterial spores, and they're not reliably virucidal against all viruses, particularly non-enveloped ones. Disadvantages also include their flammability, their rapid evaporation, which limits crucial contact time, and the fact that organic material like blood or saliva can quickly inactivate them.
So not great on dirty surfaces.
No. Next, we have aldehydes, such as formaldehyde and glutaraldehyde. These are highly reactive compounds and are notably sporicidal, meaning they can destroy bacterial spores.
Sporicidal, okay.
With prolonged exposure, as we discussed, glutaraldehyde can even act as a chemical sterilant. Glutaraldehyde is frequently used for delicate, heat-sensitive instruments that cannot be autoclaved.
Downside.
The downside to aldehydes is that they can be irritants and sensitizing agents, meaning they can cause allergic reactions in some individuals upon repeated exposure. So careful handling and good ventilation are absolutely required.
Okay. What's next?
Then there are bisquinides, with chlorhexidine being the most prominent and widely used example. This is a very common antiseptic in dentistry, often found as an active ingredient in many mouthwashes.
Chlorhexidine mouthwash, right.
Exactly. It's highly active against both gram-positive and gram-negative bacteria, and also effectively kills Candida fungi, which can cause oral thrush. Its unique and incredibly useful property, especially in the oral cavity, is its ability to bind tenaciously to oral surfaces like teeth and mucous membrane.
It sticks around.
Yes. This provides prolonged persistence, or what scientists call substantivity, allowing it to continue its antimicrobial action for several hours after application. This is why it's so effective as a mouthwash for long-term plaque control and gingivitis management.
Interesting. What else?
We also have halogen compounds, which include hypochlorites and iodine. These act as strong oxidizing agents, essentially disrupting the cellular components of microorganisms.
Like bleach.
Hypochlorites, like common household bleach, are one type. They're incredibly cheap, effective, and broad-spectrum bactericidal, fungicidal, virucidal, and even rapidly sporicidal.
Sounds great,
But they have significant drawbacks in a dental setting. They corrode metal instruments very quickly, and crucially, they are rapidly inactivated by organic matter.
That organic matter issue again?
Yes. Despite this, they're often used for disinfecting surfaces heavily contaminated by blood spills because of their potent germicidal action and low cost.
What about iodine?
Iodine and its compounds, like iodophores such as povidone iodine, are also bactericidal and have moderate action against spores. They are active against tubercle bacteria and many viruses. These are commonly used as skin disinfectants prior to surgical procedures or injections.
Okay, any others?
Phenolics are another class. They primarily act by injuring the lipid-containing plasma membranes of microbial cells, causing them to leak and die. Their main advantage is that they remain active in the presence of organic compounds, like pus, saliva, and feces.
Better with organic matter.
Somewhat better, yes. However, they are generally poorly virucidal and sporicidal, limiting their use in high-risk scenarios.
And finally, you mentioned ultrasonics earlier. What's their role?
Finally, let's talk about ultrasonics. While they are certainly an integral part of the instrument processing workflow in dentistry, it's crucial to clarify their role. Ultrasonic cleaners are primarily used for cleaning instruments before disinfection or sterilization.
So they're for cleaning, not killing.
Exactly. They work by generating high-frequency sound waves that create microscopic bubbles in a liquid bath. These bubbles then rapidly collapse, a process called cavitation, which creates a powerful scrubbing action.
Like tiny power washers.
A good analogy. This action effectively dislodges debris, blood, and organic matter from the instrument surfaces, even reaching into tiny crevices and hard-to-reach areas where manual scrubbing might miss. However, and this is a key point, they are not considered reliable for sterilization or primary disinfection on their own.
So they help with that crucial first step.
Precisely. Their vital function is to aid in that absolutely crucial pre-sterilization cleaning process. This raises an important question again. Why is that cleaning step so critical before any disinfection or sterilization can even begin? Because if the visible debris and organic material aren't removed, they can literally shield microorganisms, preventing the sterilant or disinfectant from reaching and killing them. It's like trying to wash clothes that still have mud caked on them. The soap just won't get to the fabric.
That's a great lead-in, because now that we've unpacked the science of sterilization and disinfection, from the absolute power of heat to the targeted action of various chemicals, let's connect this to the bigger picture. Why are these processes the absolute cornerstone of infection control in dentistry, and what does this all mean for you, the patient, sitting in that chair? It really makes you appreciate the incredible effort and science that goes on behind the scenes, ensuring your safety.
This is where all the theory meets practice, directly impacting your health. The dental clinic environment, by its very nature, inherently poses distinct risks for transmitting infectious agents.
How so?
Think about it. Patients bring a variety of microorganisms into the clinic, and dental procedures often involve the generation of blood, saliva, and fine aerosols, those invisible sprays that float in the air.
Aerosols, right?
We're talking about the potential for spreading serious agents like hepatitis B and C viruses, HIV, various herpes viruses, influenza, and even common bacterial infections like Staphylococcus aureus.
How do these spread?
These pathogens can be transmitted in several ways: through direct contact with infected blood or saliva, through airborne spread via those aerosols and splatter generated during procedures, or through contaminated sharps and instruments.
That sounds risky.
It can be, which is precisely why standard infection control precautions, SICPs, are absolutely fundamental and non-negotiable.
SICPs, what's the main idea?
The core principle of SICPs is a commitment that all patients are treated as potential carriers of infectious diseases, and all body fluids, with the sole exception of sweat, are considered potentially infectious.
Treat everyone the same. Assume risk.
Exactly. This universal approach means that the same rigorous precautions, the same meticulous protocols, are applied to every patient every time in routine dentistry. And proper sterilization of instruments and thorough disinfection of surfaces are not just good practices. They are the fundamental, unshakable components of these SICPs.
It's that invisible shield again.
Precisely. This is where the commitment to your safety truly shines through, offering an unseen but powerful layer of protection.
So it's far more than just a quick wipe down. Every single instrument must undergo a rigorous multi-step decontamination process, cleaning, disinfection, and then the final sterilization. Walk us through that entire journey from an instrument used on one patient to being utterly pristine and safe for the next.
The instrument journey is indeed a meticulous and tightly controlled one. The critical first step, and I cannot stress this enough, is cleaning.
Cleaning first. Always.
Always. This is the essential prerequisite to remove all visible debris and organic matter, things like blood, saliva, and tissue fragments. Cleaning is absolutely crucial because, as we touched on earlier, organic matter can literally act as a protective shield for microorganisms.
Right, hiding the germs.
Preventing the chemical agents or heat from reaching and killing them during the subsequent disinfection or sterilization steps. It's like trying to disinfect a petri dish that's still covered in food debris. The disinfectant simply won't work effectively. Automated thermal washer disinfectors are often preferred for this step in modern dental practices.
Washer disinfectors, like tiny dishwashers.
Sort of, but much more sophisticated. They provide a standardized, thorough cleaning and often a thermal disinfection step before the instruments are even sterilized. Without proper cleaning, even the most powerful sterilizer can fail to achieve its intended effect, leaving a dangerous gap in the safety chain.
That makes perfect sense. So, once they're spotless, dental instruments aren't all treated the same. They're meticulously categorized based on their risk of transmitting infection. This is where the aha moment happens for many people, understanding that it's a truly tailored, risk-based approach to patient safety. What are these crucial categories?
That's a fundamental principle of effective risk management in infection control. Instruments are rigorously categorized based on how they will be used and their potential for contact with different body tissues, which dictates the level of processing they require.
Okay, what's the highest risk category?
First, we have critical items. These are instruments that are designed to penetrate soft tissue or bone or enter the vascular system, meaning they break the body's natural protective barriers. Think surgical instruments like scalpels or dental burrs that cut into tooth structure.
Anything that goes deep.
Exactly. Because they access sterile areas of the body, these items absolutely must be sterilized. There is no compromise here. Anything less would pose an unacceptable and severe risk of serious infection to the patient. They demand the highest level of microbial destruction.
Must be sterilized. Got it. What's next?
Next are semi-critical items. These instruments contact mucous membranes or non-intact skin, but do not penetrate sterile tissue. Examples include mouth mirrors, amalgam condensers used for fillings, and those intricate dental handpieces we talked about earlier.
Touching membranes, but not cutting. What's the rule for these?
Ideally, these items should also be sterilized. However, if an instrument is genuinely heat-sensitive and cannot withstand sterilization by heat, then it must undergo high-level disinfection, which, as we discussed, kills nearly all microorganisms, but may not kill all bacterial spores.
Sterilize if possible, high-level disinfect if not.
Correct. The aim is still to minimize risk as much as possible, using the highest effective level of decontamination.
And the lowest risk category.
Finally, we have non-critical items. These are instruments or surfaces that only contact intact skin. Examples would be blood pressure cuffs, the head and cone of a radiograph unit, or the exterior surface of a dental chair.
Just touching skin.
Right. These items require a lower level of decontamination, typically low or intermediate level disinfection, because the intact skin acts as a very effective barrier against most pathogens.
And what about things labeled single-use?
Oh yes, very important. It's also vital to note single-use devices. These items are clearly identified by a specific international symbol, a circle with a number 2 and a slash through it.
The do not reuse symbol.
Exactly. They're designed for one patient use only. They cannot be reprocessed. That means they cannot be cleaned, disinfected, or sterilized for reuse under any circumstances. Once used, they are disposed of safely, immediately eliminating any risk of cross-contamination.
So no washing and reusing those.
Absolutely not. What's truly fascinating here is how every single instrument, based on its intended use and its potential for patient contact, has a very specific and rigorously defined pathway to ensure your safety. It's a completely tailored approach.
One area that might surprise you, and is something most patients never even think about because it's completely hidden, is the water lines in dental units.
Ah, the DWLs.
They are, quite frankly, a notorious breeding ground for bacteria if not meticulously managed. Tell us about the hidden network of dental unit water lines, or DUWLs, and the challenge they present.
The dental unit water lines are indeed an often overlooked and significant challenge in infection control. DUWLs are incredibly prone to bacterial biofilm formation.
Biofilm? That's slimy stuff.
Exactly. Think of biofilm as a sticky, slimy layer of bacteria that adheres to surfaces, much like plaque forms on your teeth or mold on a damp surface. This happens due to several factors inherent to their design. Their small bore tubing, the high surface area within those tiny channels, and the intermittent and sometimes stagnant water flow within them.
So narrow tubes, lots of surface, slow water. Perfect bug hotel.
Precisely. This combination creates an ideal protected environment for bacteria to multiply and form dense protective biofilms that are incredibly resistant to flushing alone.
What's the danger?
The consequence of this biofilm formation is that the water delivered to the patient's mouth can have extremely high microbial counts, sometimes reaching up to 1 million colony-forming units per milliliter.
1 million bacteria per milliliter. That's a lot.
It's incredibly high. To put that in perspective, that's potentially 1 million individual bacteria in just one tiny drop of water being sprayed in your mouth or used to cool a dental drill. This poses a significant risk, primarily of opportunistic infections. Pathogens like Legionella, SBP.
Legionnaire's disease.
Yes, which can cause severe respiratory illnesses like Legionnaire's disease, or Pseudomonads, which can cause various infections, can be transmitted through the aerosols generated by the dental unit, or even through direct contamination of open wounds if the water contacts an area where the mucosa has been breached during a procedure.
So how do dental practices maintain water quality and combat this persistent biofilm problem in the D1WLs? It sounds like a remarkably complex and ongoing issue to manage.
It absolutely requires a multi-pronged approach and constant vigilance, much like managing a complex plumbing system. First, and critically, the water delivered to patients should meet drinking water standards.
Drinking water quality. Okay.
For example, in the UK, the standard is 200 CFUs per milliliter, while in the USA, it's 500 CFUs per milliliter, a far cry from the potential million CFUs per milliliter without intervention.
How do they achieve that?
Regular flushing of DUWLs is a basic but important step, typically for 2 minutes daily at the start of the day and for 20-30 seconds between patients. This temporarily reduces microbial counts in the lines and helps flush out stagnant water, aiding in the effectiveness of other disinfection methods.
Flushing helps, but doesn't solve it alone.
Correct. Additionally, anti-retraction valves are crucial. These devices are designed to prevent the suckback of oral fluids from the patient's mouth back into the waterline tubing, which could introduce contaminants. It's a vital one-way valve for safety.
Stop stuff going back up the tube. Makes sense.
Beyond these basic physical measures, the long-term solution involves using biocides and water purifiers. These are systems or chemical treatments designed to actively remove existing biofilm or prevent its formation within the water lines.
So active treatments.
Yes. They can include inline filters, specialized chemical tablets dropped into the water reservoir, or sophisticated treatment systems that continuously disinfect the water flowing through the lines. This often involves specialized products that slowly release antimicrobial agents into the water.
And what about during surgery?
Yes. A very specific and critical exception. For surgical procedures that involve breaches of the oral mucosa or exposure of bone, sterile solutions of coolant or irrigant must be used.
Sterile water, not from the unit.
Exactly. These solutions are delivered from separate, sealed, sterile sources, entirely bypassing the DUWLs to eliminate any risk of contamination from the unit's water system. This illustrates the depth of the commitment to patient safety.
Wow.
If we connect this to the bigger picture, it's a testament to how deep the protocols go, even into the water itself, to ensure patient safety. It's a hidden layer of protection that truly illustrates the thoroughness of modern dentistry.
It's clear that safety isn't just about the instruments or the water. The entire environment plays a crucial role. How do these principles of infection control extend to the surfaces around the dental chair and even the materials sent to the dental lab?
Indeed, the scope of infection control extends far beyond just instruments and water lines. It encompasses the entire clinical environment. Environmental disinfection is crucial for preventing cross-contamination from surfaces.
What kind of surface?
Clinical contact surfaces. These are the high-touch surfaces that are frequently contacted by the dental team's gloved hands, instruments, or blood saliva splatter. Think of light handles, switches, countertops next to the patient, chair controls, and even the doorknobs within the treatment area.
Stuff touched during treatment.
Right. These must be meticulously cleaned and disinfected between every single patient. This is ideally achieved by using protective barriers, like clear plastic wraps that are changed between patients, or by using intermediate or low-level disinfectant wipes for a thorough clean.
And things like floors.
Housekeeping surfaces, such as floors and walls, which have less direct patient contact, should still be regularly cleaned with a detergent and warm water or a hospital-grade disinfectant to maintain overall hygiene and a clean clinical appearance.
And what about stuff sent out, like impressions?
And then there's laboratory asepsis, which represents another critical link in the chain of infection control that many patients never consider. dental practitioners have a direct professional and ethical responsibility to ensure that any clinical material sent to off-site laboratories, things like impressions of your teeth, dentures that need repair, or biopsy specimens, are thoroughly cleaned and disinfected before they leave the clinic.
Disinfected before going to the lab. Why?
This is absolutely essential to obviate any infectious hazards during transport to the lab, and crucially, to protect the dedicated staff working within the dental laboratory who will be handling these materials directly. It's about ensuring the chain of infection prevention remains unbroken, protecting everyone who comes into contact with potentially contaminated items.
Protecting the lab techs, too. Makes sense. Finally, there's a particularly difficult challenge for sterilization, something that really highlights the extremes of infection control and how incredibly resilient some pathogens can be. Tell us about the ultimate challenge.
Prion diseases.
Prions. They are a unique and truly formidable challenge in the world of sterilization, almost a category unto themselves.
What are they exactly? Not bacteria or viruses.
No. They're not living microorganisms like bacteria or viruses. Instead, they are infectious proteins. They are responsible for a group of rare, fatal neurodegenerative diseases, such as variant Creutzfeldt-Jakob disease, VCJD, which gained notoriety in the context of mad cow disease.
Infectious proteins. How are they infectious?
They cause normally folded proteins in the brain to misfold, leading to a chain reaction and devastating damage. The terrifying aspect from an infection control perspective is that prions are extremely difficult to destroy by routine sterilization methods.
Harder to kill than spores.
Much harder. They are remarkably resistant to standard heat, chemicals, and radiation protocols that would easily kill virtually every other known pathogen. Think of them as tiny, indestructible puzzle pieces that can reassemble and cause disease.
Wow. So what do you do if a patient might have a prion disease?
This extreme resilience necessitates very special, rigorous precautions when treating patients with known or even suspected prion diseases. The measures are far more stringent than standard protocols. This might involve using single-use, disposable instruments for these patients, ensuring they are immediately incinerated after just one use to completely eliminate any risk of transmission.
Just throw everything away.
Ideally, yes. Alternatively, if reusable instruments must be used, they require extended sterilization cycles, sometimes up to 18 minutes at 134 degrees C, in dedicated autoclaves, and often preceded by specific, strong chemical treatments designed specifically to denature these exceptionally tough proteins.
Extra long cycles, special chemicals.
Exactly. What's truly fascinating here is how even the most robust sterilization methods need specialized adaptation for these truly resilient pathogens, showing the constant vigilance, research, and adaptation required in this field to maintain the highest levels of patient safety.
So, what does all of this mean for you, the patient, and for the dental profession at large? We've taken a deep dive into the meticulously designed and scientifically backed world of dental sterilization and disinfection. We've explored everything from the absolute certainty of autoclaving to the nuanced choices in chemical disinfectants and how these rigorous multi-layered processes safeguard every single visit to the dentist, ensuring your well-being. It's a complex, multi-layered system, all designed with your safety as the absolute top priority.
It truly is about a multi-layered approach, a comprehensive strategy where meticulous cleaning, followed by appropriate sterilization or disinfection and constant vigilance, all supported by rigorous monitoring and comprehensive staff training, work in concert. Each step minimizes risk and collectively ensures a safe, hygienic environment for everyone who steps into a dental practice. It's a testament to the scientific rigor applied daily, often invisibly, to protect public health.
The next time you're in the dental chair, perhaps you look around with new eyes, appreciating the invisible shield of safety that surrounds you. But beyond that, consider this. How might these same principles of meticulous layered infection control the cleaning before disinfecting, the risk-based categorization, the constant vigilance for hidden threats like biofilms apply to other areas of public health, or even to our own daily habits in ways we rarely think about?
That's a great point. This raises an important question. If such rigor is required for dental health, where else might a deep dive into unseen protocols and meticulous processes reveal critical layers of safety and care that we often simply take for granted? It's a powerful reminder that much of our health and safety relies on unseen, diligent processes carried out by dedicated professionals.
Thank you for joining us on this deep dive. We'll see you next time.